Good morning. On behalf of my co-chair, Dr. Oberg, I will be opening the second part, or section number 2. This section will deal with novel agents for therapy of neuroendocrine tumors. This is an area I think is really exciting for this field, where there has been some major advances with new agents, new pathways being explored. So it's my pleasure to introduce the first speaker, Dr. Gross, who's going to talk to us about peptide receptor radiotherapy.
Good morning, everyone. I would like to share our experience with you with treatment of patients with neuroendocrine tumors with radioactive ligands of somatostatin analogs. The patients are all under treatment at our center in Jerusalem. Oops. And just a few words on the biology behind this treatment. Basically, what we're doing here is conjugating a radionuclide up there, using a conjugate, in this case DOTA, to an analog of somatostatin. So we get this complex here, which is more or less like a guided missile. This is our warhead, and this is our delivery system. And the somatostatin analog will target upon its receptor, and upon binding to the receptor, it is internalized with the receptor into the cell and will localize the cell and will irradiate the cell and the adjacent area. There are two radionuclides now that are in use, primarily in Europe. One of them is labeled with yttrium-90, which is a high-energy beta emitter, and the other one is lutetium-177, which is a medium-energy beta emitter. Each of them has its relative advantages. It is thought, and there's some preclinical evidence for that, that the yttrium-90 label compound will be more effective in large, poorly vascular tumors, whereas the lutetium-177 will be more effective in small tumors that are more miliary appearance. Our patients were treated at two centers. The first patients were treated with the lutetium compound at the center in Rotterdam, where this treatment was actually pioneered by Eric Krennig and his group. And the majority of the patients received both, either yttrium or lutetium, or sometimes a combination of both, at the center in Basel. How does one assess whether a particular patient will be amenable to treatment by PRRT? It was shown by the Krennig group that if you have high uptake of a tracer by the, where is this? Ah, there it is, sorry. If you have high uptake of tracers, here you have metastasis on an Octreoscan, then this will predict a positive response to subsequent PRRT, and this can be graded, and there's a so-called Krennig score, where if you have uptake in a lesion that is equivalent to the liver, this is Krennig grade 2, above the liver it's grade 3, and the highest grade is when you have uptake that's higher than the kidneys and the spleen, which physiologically take up the highest amount of this tracer. So, which patients were included in the study? They had to have a Krennig score of over 2. They should have a good performance status. They had to have reasonable synthetic liver function, because most of these patients had a high tumor load in their liver. Their albumin was over 3 grams per deciliter. And they also had to have a blood count with these parameters at least, and also the kidney function had to be above a certain level of creatinine. I'll show you a summary of the results between 2002 and 2008. 65 patients were treated during this period, more or less the same number of female and male patients. The age appears down here. And this is the distribution of different kinds of tumors. As in the general population, the well-differentiated pancreatic neuroendocrine carcinoma, the non-functioning ones, were the predominant patient population. The following were midgut carcinoids, then we had a variety of other carcinoids, some functioning pancreatic neuroendocrine tumors, and some rare entities down here. 55 patients were treated at the Basel Center, 10 patients at the Rotterdam Center. The Basel protocol is usually 2 treatments with 200 millicuries of yttrium, which were about 6 to 8 weeks apart, again, depending on the effect of the treatment on different parameters such as blood counts. In Rotterdam, usually the treatment was given 3 to 4 times at 1-month interval. Here, the isotope was 177 lutetium alone. And these are more or less the results that we achieved here. I should point out that these are not RECIST criteria, but this was assessment by our in-house radiologist if the tumor seemed to respond appreciably or to a minor extent or remained stable. So as you can see here, in about 35% of the patients who had pancreatic neuroendocrine carcinomas, a partial response was noted. Another 6% had a minor response, and stable disease was in about 40% and more of the patients. You can see that in midgut carcinoid patients, partial responses were rare, but stable disease was more, the more dominant kind of outcome in this group of patients. And there were patients who, in this group, who progressed, 29%, in the PNET group, about 15%. I should mention that not all patients had progressive disease at the onset. Some of them were treated because of either symptoms or our impression that if we waited a bit more, we might lose patient function or organ function that would preclude any kind of patient. So that was our philosophy for actually treating patients, either progressive disease or symptoms or our feeling that organ function might be compromised if we waited longer. And this comes to show you that the duration of response in the responder groups, where we included partial, minor response, and stable disease patients, 48 patients, you can see that we had a median time to progression of about 2 years. This is the biochemical response. What you have here is non-responders and responders, and you can see that the difference between these two groups is that in none of the non-responders did we see a decrease in chromogranin A. In some of them it remained stable, and then in none of the responders, except for one exception, did we see an increase in chromogranin A. In most, we saw actually a decrease to some extent, and in some it remained stable. Symptoms. 26 patients were symptomatic and had pain which was predominantly abdominal or in the bone at the entry to the study. In about half of these, we saw an improvement, and in the other half there was no change. I should mention, however, that there were 7 patients who had no pain on the onset of the study that developed pain at assessment post-PRRT, and we have a number of thoughts about this. Diarrhea, which was not infrequent, obviously, in this patient group. 19 patients had diarrhea at entry. In about half of the patient group, we saw complete resolution. In a smaller percentage of patients, we saw improvement. And in the remainder, we saw no change, and we did not see any deterioration of this symptom in our patient group. Well, this is just to remind you what ECOG is, but I'm sure most of you in the audience are conversant with this classification. And what we did was we saw that in the survivors, there was a downgrading of the ECOG performance status after PRRT. You can see, for example, here, no, this is survival. I'm sorry. This is the wrong. This is the survival of the patients. There should have been an ECOG slide here. I apologize. But anyway, you can see that the patient survival here is obviously related to response to PRRT. If you did not respond to PRRT, your chance of survival was less than if you did. Okay. Adverse effects. We divided the adverse effects into early adverse effects and late adverse effects. The early adverse effects were usually not very serious, included nausea and weakness, usually immediately after the PRRT, sometimes up to 2 to 3 weeks afterwards, but usually subsided and the patient went back to the normal routine. There were some patients that had a headache, fatigue, and I must say that we had one patient that died on site after receiving PRRT, but we believe it was unrelated to the treatment. These are the later effects that were classified if they appeared after 1 month of treatment. We saw anemia in an appreciable group of patients, leukopenia, thrombocytopenia. There was also weight loss. We did see some elevation of serum creatinine in our patients. In 2 patients, it was previously normal, so usually the predisposing factor was some degree of compromise of renal function prior to PRRT, and there were a number of other side effects. One effect that hasn't been reported in other reports is premature ovarian failure that we noted in women that were still at the reproductive age. And I just want to present 2 demonstrative reports. The first is a patient who had a PTHrP-secreting, well-differentiated pancreatic neuroendocrine carcinoma. He was 57 years old. He had severe abdominal pain. He was hypercalcemic. He lost weight. He had a large pancreatic mass with liver metastasis. He had been previously treated with octreotide LAR monthly, and he was subjected to 2 courses of yttrium DOTATOC, and we noted post-therapy a clinical biochemical and radiological response. The patient, who was previously confined to a wheelchair, became completely independent and gained back the weight that he lost. And what you can see here are 2 very large metastases in the liver, over here and over here and over here and over here. Now, if you went according to RECIST criteria, you would say that this patient did not respond because the size of the lesions is actually quite the same. But if you look at the degree of necrotic lesion to viable lesion, and you can see that there's a marked increase in the necrotic component post-PRRT. So this, again, maybe illustrates the problematics of using RECIST for assessment of patients with NET patients for assessment of treatment response. So RECIST has its place, but we should be careful and beware that it does not always reflect response to therapy. And this shows the same thing in an Octreoscan. Again, we can see the uptake in the two metastases in the liver, hyper intense. And again, you can see here that there's a certain degree of necrosis in the middle of the tumor. And when you look after treatment, you can see here that you have this rim of viable tissue and a much larger component of necrosis. The second patient was a 56-year-old woman who had developed abdominal pain, jaundice, and diarrhea, had a Whipple's procedure for a head of the pancreas neuroendocrine tumor, which was pleomorphic endocrine cancer. In 2003, she developed, which was 5 years later, multiple bone and liver metastases with the attendant clinical signs of abdominal pain, weakness, fatigue. And she was treated in this case with 4 courses of lutetium octreotate, again, with very impressive improvement of her symptoms, and also an objective response, as can be seen here. You can see a large metastasis in the right lobe of the liver, and you can see how it has regressed after treatment with lutetium. Our series is relatively small, so we're now reanalyzing. We have 140 patients. We're going to reanalyze it a bit more carefully and use RECIST criteria and other criteria. But we compared it to what appears in the literature, and what you can see basically is that you rarely see a complete response after PRT. Okay, this is a rare occasion. We haven't seen any in our patients. In about 20 to 30% of the patients in most centers, you can see a partial response. Stable disease, and most of these patients were progressive patients. Okay, you can see a stabilization in about 35 to 65% of the cases, and progressive disease in a minority of the patients. I must state one more observation that we have noted, that in 3 patients that had diffuse disease and were amenable to curative surgery after receiving PRT, one of these patients underwent further surgery and is free of disease. And there are 2 additional patients, all 3 with PNETs, I should mention, that are now being considered, 2 additional patients are being considered for curative surgery after reduction of their tumor mass by PRT. So, our retrospective results compare favorably with the European experience. There's a high therapeutic to adverse effect. There's a relatively high progression-free survival, especially when we compare this to the standard to chemotherapy and responders. And we believe that PRT is an effective treatment for appropriate patients with metastatic neuroendocrine tumors. Thank you very much.